High-frequency pornography consumption leads to two divergent outcomes. For some, it is a tool for shared intimacy. For others, it spirals into secrecy and distress. The sheer scale of modern consumption illustrates why these paths diverge. Currently, an estimated 12% of the entire internet consists of pornographic material. This volume is driven by three specific sociological factors: access, affordability, and anonymity. This AAA engine normalized high-frequency consumption across almost every demographic within a single generation. Early clinical responses often conflated this high frequency with behavioral addiction, applying models originally designed for chemical dependencies to a ubiquitous digital behavior. The current clinical standard is narrower. The ICD-11 classifies compulsive sexual behavior disorder as an impulse control disorder, explicitly stating that a diagnosis should be made regardless of moral disapproval. Because high consumption is statistically normative, clinicians must analyze the underlying neurobiology and behavioral context rather than relying on frequency alone. This distinction is necessary to avoid over-pathologizing healthy sexual behavior. In clinical literature, problematic pornography use, or PPU, is an umbrella term for consumption accompanied by subjective distress or a perceived loss of control. PPU exists on a continuum, ranging from temporary maladaptive coping mechanisms to severe, functionally impairing behavioral dysregulation. We must also distinguish PPU from generalized hypersexuality, as a naturally high sex drive does not equate to clinical pathology. The primary challenge for the modern clinician is identifying specific drivers behind a patient's self-reported distress. Effective treatment requires categorizing a patient's presentation into one of three distinct clinical frameworks: coping, moral conflict, or true dysregulation. This two-axis framework evaluates patients reporting pornography addiction by plotting functional impairment against subjective distress. The first clinical profile, landing in the high distress, moderate impairment quadrant, represents pornography used as a maladaptive coping mechanism to regulate negative affect. This profile operates through negative reinforcement. Patients utilize the dopamine and norepinephrine release triggered by orgasm to temporarily mitigate feelings of loneliness or depression. According to operant learning theory, if this distraction successfully reduces an unpleasant mood, the behavior will likely be repeated during future episodes of distress. While this reliance causes significant psychological distress, it rarely results in a total loss of functional control over daily responsibilities. In these cases, the pornography use is a symptom of underlying mood dysregulation rather than a standalone addiction. A second common profile lands in the high distress, low impairment quadrant, categorized as moral incongruence. Here, the patient's distress is driven by a conflict between their consumption and their cultural or religious beliefs, leading to severe negative self-evaluation despite high functional control. The ICD-11 warning is specific. Clinicians must rule out compulsive sexual behavior disorder if the distress is purely moral. This contrasts with true compulsive sexual behavior disorder, located in the extreme high distress, high impairment quadrant. This quadrant requires evidence of persistent failure to control impulses, escalation, withdrawal, and severe occupational or interpersonal consequences. Failing to distinguish between these profiles leads to the misapplication of treatment protocols and the potential over-pathologization of normal behavior. This clinical mapping also challenges the claim that high-frequency pornography use structurally degrades the human brain. Individuals reporting problematic pornography use show increased activation in reward processing regions like the ventral striatum and prefrontal cortex, alongside a negative correlation with gray matter volume in the right caudate. However, current evidence relies almost entirely on cross-sectional fMRI studies. These provide a single snapshot in time, rather than tracking a brain's structural changes over a longitudinal span. Without longitudinal data, we cannot determine if these neural signatures are caused by pornography, or if they represent pre-existing vulnerabilities to novelty and reward-seeking. Severe dysregulation often aligns with incentive motivation theory, creating a wanting versus liking paradox, where a patient neurologically craves the stimulus, while reporting no actual pleasure upon consumption. While reward pathways are involved, the current neurological data does not support a universal brain damage model similar to chemical substance tolerance. The relational context of consumption further dictates the clinical outcome. Empirical findings show that mutually agreed upon shared consumption correlates with enhanced sexual communication and relational connection. In contrast, solitary, secretive consumption correlates with relationship dissatisfaction and a diminished perception of partner appeal. Pornography acts as a relational amplifier. It exacerbates existing communication gaps or deepens established intimacy based on the environment in which it is used. This psychotherapeutic matrix demonstrates that treatment must be matched specifically to the patient's diagnostic quadrant. For the maladaptive coping profile, cognitive behavioral therapy, or CBT, is the primary intervention. CBT targets distorted beliefs about sexual satisfaction and utilizes behavioral activation to replace the pornography-driven dopamine loop with healthier emotional regulation strategies. Acceptance and commitment therapy, or ACT, is more effective for moral incongruence and urge-driven profiles. ACT builds psychological flexibility, teaching patients to observe sexual urges without immediate judgment. This reduces the power of the shame cycle. Deep-seated relational dysfunction is addressed through psychodynamic and family systems therapy, using systemic interventions to resolve underlying emotional alienation. Clinical success depends on dismantling the patient's specific behavioral architecture rather than merely treating the digital symptom. The dual effect framework characterizes pornography as a potent stimulus capable of yielding both enriching outcomes and severe behavioral dysregulation. The clinician's role is to objectively assess functional impairment and the true drivers of a patient's distress. By moving beyond the generic addiction label and embracing diagnostic heterogeneity, the psychiatric field can provide targeted, proportional, and effective care for modern sexual health.